This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 31, Bariatric Medicine. Key concepts. Upon completion of this chapter, you will understand the common health risk associated with obesity, the pathophysiology of obesity, the difficulties of BLS and ALS treatment, plus the transport of obese patients. Chief concern. Metropolitan life insurance tables were early efforts to describe weights that were normal and abnormal, and Metropolitan life essentially tied weight to longevity. The purpose was assigning risk to life insurance. Now, obesity, this is a term, which means greater than 10% over your ideal weight. Morbid obesity, greater than 30% over your ideal body weight. Chief concern continued. The body mass index was created out of concerns over validity of the Metropolitan life insurance and a desire for better description of obesity. And this is figure 31-1, the body mass index chart in your book. Health risks associated with obesity are very numerous: cancer, diabetes, hypertension, stroke, coronary artery disease, non-alcoholic steatohepatitis, which is essentially a fatty liver, causes some of the same problems that we see from a liver that has cirrhosis. So they'll get jugular venous retention and osteoarthritis. Lots of weight on the joints cause damage and inflammation. Diabetes, there's a close correlation with diabetes and obesity. Type 2 diabetes, to be more specific. The patient with obesity has a threefold risk of developing diabetes: insulin resistance and hyperinsulinemia. Essentially, all the adipose tissue also makes an increased cellular demand upon the body. That increased cellular demand requires more insulin, and the more insulin that you secrete, the more resistant your cellular compartment becomes, and that provides a resistance to your own insulin. Now, the type 2 diabetic takes medications that assist with this, and things like metformin, Lantus, and that's an injectable type of insulin, long-acting. They can also be on normal insulin regimens as well to kind of overpower the cellular compartment. Cardiovascular complications. Adipose tissue needs oxygen, glucose hormones, and everything else that every other cell needs. Creates a need for new blood vessels and an increase in systemic vascular resistance, and an increase in blood volume as needed. All of these new tissues and these new cells require vascular beds. The heart increases its stroke volume and rate, and because of this, all this increased demand, secretes adrenaline, increased force and rate of cardiac contraction through stimulation of the beta sympathetic receptors to increase cardiac output, and this leads in general to systemic hypertension. The heart of the obese patient has to overcome this response. So increased vascular beds, increase adrenaline, the alpha response of the adrenaline increases the blood pressure. So it essentially leads to cardiomegaly or an enlarged heart, and can throw them into pump failure quite easily. Pulmonary complications, oxygen demand, the increased cellular environment, the adipose tissues are metabolically active. And then all of the underlying supportive muscles become active as well. Lungs must increase their production to meet the needs, and that includes the respiratory rate and the depth of the respirations. Complications, hypoxia, most pronounced at night whenever the patient is sleeping, and can result in sleep apnea. Polycythemia, often seen in patients with COPD or chronic obstructive pulmonary disease, such as emphysema. that increases the viscosity of the patient's blood. They can also become lethargic, somnolent, or sleepy, and they can get Pickwickian syndrome, which includes morbidly obese patients with transient hypoxia, hypercarbia, or retaining CO2, and often obstructive sleep apnea. And figure 31.3 are complications of obesity. And these include stroke, hyperglycemia, sexual dysfunction, atherosclerosis, high blood pressure, and heart failure and renal failure. As far as history goes, ascertain their shortness of breath or if they've had it, obtain a standard history, paroxysmal nocturnal dyspnea or shortness of breath at night, or orthopnea, need to sit upright to breathe properly. Their weight may be a factor in this, and they may be very sensitive about the topic. Explain the importance for the care and the questioning in the history. On examination, body habitus, physique that when observed would cause the paramedic to suspect certain medical conditions that may coexist. Examples of this would be heart failure. Cardinal signs of cardiac disease or heart failure are things like jugular venous distension, pulmonary edema manifested by rowels, ventricular gallop whenever you're listening to S1 and S2, hepatojugular reflex and reflux, kind of like saying potato on the reflex versus reflux. The actual assessment is applying pressure to the abdomen and watching for about 10 to 30 seconds and watching the jugular venous distension. However, that will cause congestive heart failure while you're doing that. Peripheral dependent edema, this would be like +2, +3, +4 edema. The hepatojugular reflex is assessment greater than 45 degrees of jugular venous distension. And then peripheral cyanosis. Vital signs. Morbidly obese or chronically hyperdynamic. Expect persistent tachycardia in these types of patients, and the body habitus makes obtaining vital signs very difficult. Examples of this: it may be difficult to find the pulse points. It may be difficult to assess the respirations because of large amounts of tissue, auscultation of the lung sounds from the same reason. Need to obtain a reliable blood pressure. So we may have to move a normal blood pressure cuff down to the forearm and take it at the wrist to assess their actual blood pressure. And treatment considerations. If they're so large that it's difficult to get them ventilated, nasopharyngeal airways, even on a conscious patient, should be considered for the use in a patient that is somnolent or having sleepiness or an altered LOC, secondary to carbon dioxide narcosis. Positioning them, upright or high Fowler's position would be the best position. Oxygen administration, high flow, high concentrations of oxygen. Manual ventilation with BVM, bag valve mask assembly. Very simply, if they're having a hard time breathing, sometimes we can assist their ventilations and get them out of this slump. Advanced airway modalities. Intubation, the key is to position. Everyone will take a look at this here for just a second. That this patient is in a good inline neutral position. Even if he had an anterior airway, our laryngoscope using the right directions will give us a better chance of facilitating an intubation. Always remember your hallmarks on this, 332, and that we took a look to see what kind of Mellon-Potty score that they might actually have before trying to intubate them. The SOAP mnemonic means things at the standby, a good thing to remember whenever we're fixing to facilitate an intubation. Suction, oximetry, airways, multiple types, and a backup airway, and pharmacology at the standby. Medication administration. First, choose the route, and then the morbidly obese patient, IV access may be problematic. Consider an IO needle. However, even the book suggested that maybe a sternal IO would probably be the best, and this would be following your local protocol. The yellow needle, which would be the large tissue needle, may not be long enough to facilitate an interosseous. Patients with obesity have altered pharmacodynamics as well. They have an increased volume distribution, increased half-life elimination, and decreased clearance of fat-soluble medications. Transport. Consider Considerations on transport: encourage a culture of safety. There are places that would have a no-lift policy. Using more technology. Examples of this would be lift devices that would bring the patient up to the level of the cot so we didn't have to lift them, which would include mechanical devices, patient lift teams, and so on. Special provisions for transport. Figure 31.6 of the next slide is a transfer ramp, and this would be to facilitate getting the patient, when placed upon the cot, into the back of the ambulance. Upon evaluation, post-obstructive pulmonary edema, patient holds their breath while being laid flat. The airway becomes occluded. Consider that. Treatment: raise the head to a seated position immediately and apply high flow oxygen, high concentrations of oxygen. And think about considering continuous positive airway pressure, or BiPAP if you have it. Position: be familiar with hospital's capabilities on disposition, the equipment for larger patient care. Examples of this would be bariatric wheelchairs, bariatric beds, heavy-duty Hoyer lift systems, and open CAT scans. In conclusion, obesity, significant public health issue in the United States, linked as a primary cause of several chronic medical conditions. Assessment and treatment presents a challenge to the paramedic. The paramedic must employ several tools at his disposal to help safely care for these obese patients. References were taken from Myers Professional Paramedic, Medical Emergencies, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandcc.edu, or 405-219-7613. Thank you.